So I welcome you all for E-Gurukul Pathshala, our PG clinic program. And that is very much favorite in all the PGs. Also very favorite in all the PGs of India even. So I get many feedbacks and people enjoy whatever is discussed over here. Especially thanks to Mahadev sir. Even I get many comments from the experts also that sir was doing excellently. So we are always thankless to the sir. So much thanks. So today we have case discussion on endocrinology. I haven't specifically told this is the what about we are going, because as sir says, patient doesn't come with the system that I am coming from this system. So that's why not a proper diagnosis we are writing as a case discussion. But yes, it is mainly the endocrinology we are going to discuss today. For this, we have a case presenter, Dr. Nitisha. She's a third year student from GMC Bhavnagar. And I also welcome her mentor, Dr. Shipra Agrawal. She's assistant professor at GMC Bhavnagar. Today, for the case discussion, we have an eminent expert, Dr. Shalmi Mehta. Shalmi madam, actually in Ahmedabad, nobody needs introduction of Shalmi madam. Everybody knows her as a pioneer in pediatric endocrinology in Ahmedabad. She was the first one as a pediatric endocrinology in the state of Gujarat. Started with the endo kids, and we all know that whenever the pediatric endo, it is Shalmi ma'am we are going to ask her something. So she's practicing endocrinology since so many years. She's convener for the growth chart training of IIP Gujarat, and she has authored many chapters plus in the textbook of pediatric endocrinology, IIP STGs, and other journals. Speakers at many conferences and mentor for the diabetes educator training, Ideal by ST. So welcome, ma'am.
Thank you so much. Thank you.
I hand over this platform to Dr. Baldev Prajapati sir, our mentor and our guide. Welcome, sir. The platform is all yours.
Thank you very much, Dr. Neha. Good friends, welcome to this, I will say, most dynamic learning platform. And I'm sure that not only the learning for the students, but for all of us. And I think no any other method than the case discussion is the better method for learning the medicine. And I'm sure that here with this presentation from Dr. Nitisha and expert comments from Dr. Shalvi, anyone, I will say, participation of other students will make the discussion interesting. Nitisha, I think you can request your other colleagues to join.
Yes, sir. My colleagues have already joined, sir.
Okay. Dr. Manali, she's from your place?
Yes, sir. Dr. Manali, Dr. Ravi, sir.
Dr. Ravi, yes. And I request both of them that please keep your video on. And participate in the discussion very freely. All of us are, I will say, general pediatricians. We start the discussion. Something, suppose some super specialty comments required, Dr. Shalmi is there for us. So I think no problem. But we should participate in the discussion very freely. With these few words, I request Dr. Nitisha to start her presentation with the history part.
Yes, thank you, sir. Is the screen visible? Is the presentation visible, sir?
Yeah, can you make it full screen? Yes, fine.
Okay, sir. Good evening, everyone. I'm Dr. Department of Pediatrics. Today, I will be presenting a case in E-Gurukul Pathshala under the mentorship of Dr. Shipra Agrawal. The informant is a mother who is reliable. The patient is a 6-year-old female child named Sandhya Munnabai Dhapa, presented to pediatric OPD with the chief complaint of child not gaining adequate height from 1 year of age. History of presenting illness. Parents noted that the child is their child is not gaining adequate height from 1 year. She is short when comparing to other girls in the same age group. She is not outgrowing her clothes and shoes. Younger siblings are of normal height. Weight gain is also less and delayed dentition. The central incisors erupted first at 13 months of age. In the negative history,
Okay, I think Dr. Nitisha, can you just stop sharing?
Yes,
We'll take
okay,
the
sir.
negative history after this
Okay, sir.
first 2 slides.
Okay, sir. Yes, sir.
I think let us focus what she had made the statement that here the 6 years old female is brought and mother complained regarding the short or I would say less height of her daughter. Even she added that this observation since the age of 1 year of the child. I think the very first question which I would like to make, that's very common in our daily OPD, that mother comes and complains of that she's short, she's not growing, not gaining the height. I'm sure that you must be listening, very common complaint in the OPD. Forget regarding everything what Dr. Nitisha already stated. How will you take it, Dr. Ravi or Dr. Manali? That any mother complains of short or I would say not gaining the height of her child, son or daughter. How will you address that complaint? Let us take, I will say, from our basic daily what we are working. Very good. Yes, Ravi has appeared. Nice. Ravi, how will you take?
Sorry, sir, I didn't get your question, sir.
Yeah, I think very common daily complaint which we are, I would say, getting in our OPD many a times that for whatever the problem the child is brought to you. Maybe simple upper respiratory or even fever or antic or anything. But with that, she complains that this particular my child is not growing well, not getting the height. It's very
Yes, sir.
short, even in his or her class. I think very common complaint.
Yes, sir.
Listening to this complaint, how will you take it? That means how will you perceive? Or how will you try to gather the further information? Or how will you decide that really is it short or not? Because most of the times, what most practitioners are, I will say, responding that okay, many children remain short, then they grow, don't bother, right? Or at least they will prescribe some iron, calcium, some even I will say tonics, which probably may not be the right approach or answer. So how you will take it?
So generally, if any patient came to OPD with short stature, I will measure the height and according to plot in growth chart according to the.
Very good.
And is there any familial short stature is there? Yeah, any chronic infections or any abnormal facial
My
features?
first question. Okay, I think regarding cause or etiology, we'll focus later on. But how will you decide that really, yes, what she complaining, mother is complaining, is really valid complaint? That means child is short, certainly, for that age. How will you decide? I think you started very nicely. That first measure the height. And second, you said that you will plot on the growth chart. Very fine. But then how will you decide? I think regarding cause, etiology, we'll see later on. Because we do not know in every child what's the problem.
Yes,
and
sir.
suppose so obvious, we may not go for the whole exercise. But the very, very valid point, first we should have some solid reason, basic some explanation or understanding that what she's complaining, the short taste of the child is really valid, is really short or not.
Yes,
If really, if you are convinced that it is not short, you can explain the mother that look at the growth, and then
Yes,
you
sir.
can explain that your child is not short, don't worry. But
Yes,
suppose really, if you are convinced that yes, child is short, but how will you decide that yes, child is short? First,
Sir,
I will appreciate measurement of height. I will not go into the details. That otherwise, that is also very important. The technique of measuring the height.
Yes, sir.
And I'm sure in the examination, teachers or examiners are going to ask you. Right. So that part is
Yes.
also important. We'll address it some, I would say, later on. But first, the
Yes, sir.
measurement of height appropriately, and then plotting on that is also right growth chart.
Yes,
Right.
sir.
Particular growth chart, male or female, that selection, everything I hope that you know and you will do accordingly. Okay, now you are plotting.
Yes.
Now what will you do? How will you decide?
Yes. Sir, if patient height is less than third percentile, yeah, 2 standard deviation, then we have to consider that patient have a short stature. So then we have to
Okay.
work up for the patient of etiology, sir.
Okay, suppose already in my child, my patient,
Yes, sir.
is the measurement of height I plotted and it is less than third percentile.
Okay, sir.
Okay, should I start this, I will say, exercise of investigations or something?
No, sir. No, sir. We have to assess. I have to rule out any etiological factors like any chronic infections. If there is no
Anyway,
any other
I think that part again will go later
okay,
on
sir. We
regarding
have to
etiology.
we
But
have to regularly
Ravi, what is my point?
monitoring the patient.
Ravi, what is my point? That from that particular reading,
Yes, sir.
should I make up my mind that yes, child is short? Or
Yes, sir.
that is not sufficient?
Okay, sir. Sir, we have to check mid-parental height, sir.
Okay. So what is my point? That maybe even less than third percentile,
Yes, sir.
but still, really truly the child is falling in the definition or category of short stature or not, that we'll have to see.
No,
Okay,
sir,
suppose, how will you, let me go to even other your colleagues. I hope the Manali is there, or Megha. Dr. Megha, please come on. Make your video on. I can at least look at you, and we can have the interactions. At least Ravi has, I will appreciate that he has started this discussion.
Consequent measurement of height and height velocity we have to check for the patient.
Okay, how will you decide the mid-parental height? Can you tell me this? I think this may be the very superficial or basic discussion. Dr. Salvi
Yes, sir.
might be getting bored, but I'm sure that this is more important for general pediatrician like ours. And I'm sure that if you need appropriately, our thoughts will be right. So
I think this is the most important aspect, and most of the investigations can be prevented if we have these basic things. So I think this should be stressed upon more and more.
Absolutely. I think we'll take the final word from Madam before that, at least students. Yes, Ravi. How will you decide this, measure the mid-parental height? How will you decide that yes, this is mid-parental height?
Sir, maternal height plus paternal mother height and father height divided by 2. If in case male patient plus 6.5 centimeter, if it is female patient minus 6.5 centimeters.
Dr. Nitisha, why we go for the plus minus 6.5? Is there any explanation? Why we go for this, I will say, simply mother side, fathers divided by 2. But by the for boys plus 6.5, for a girl minus 6.5 to decide the mid-parental height. Is there any idea?
Yes, sir. If we write that formula in a
Nitisha, I think your net is having the problem. Can you try to adjust it if possible?
What, sir?
In between, your voice is breaking due to the net issue, probably.
Hello?
You are audible. Please carry on.
Sir, so when we write, if we write the same formula in another way, it becomes like mother minus 13. If it is a female, the whole thing divided by 2. So that 13 centimeter comes from the genetic, the difference between the two genders. It is assumed that mostly the male will grow up to be a longer height than female. And that difference is average around 13 centimeters.
Okay, let us try and understand this point from Dr. Shalmi. Madam, can you explain that why we go for this plus minus in a boy and girl?
Yes, so generally a boy tends to have the growth spurt a little later as compared to the boy, right? So they have a growth spurt about 2 years later than the boy. So if you look at the puberty of any girl, they start having the growth spurt at B2. Whereas in a boy, they will have the growth spurt when the SMR staging is between 3 to 4, right? So they usually tend to grow about 2 years more as compared to a girl. So around 5 centimeter per year, they'll grow an extra, right? At the same time, the growth spurt in the boys is slightly more. So around 3 centimeters more as compared to the girls, right? So that is why that 13 comes. So if you look at a family, 13 centimeter is usually the difference. I'm saying usually between a brother and the sister of the same family, right? So brothers are usually taller by about 13 centimeters as compared to the sisters, right? So that is why they're 13. So earlier it was plus minus 8.5, it was a 9.5, but gradually it has come down to a smaller and smaller, more accurate value of plus minus 6.5 centimeters on both sides for the boy and minus 6.5 for the girls.
Interesting. I think we should know that why this formula derived like this. Okay, let me back to you. Having suppose you decided with parental height, now what will you do? Suppose you calculated as per the formula, you got some figure, now what will you do?
Yes. So next we will go for
Nitisha, you can take it further.
okay. Sir, we have to calculate the target range for this patient, sir, for this child, sir, because it is not necessary that exact the adult the child will grow up to be adult with that exact mid parental height, sir. So we have to take a range, sir, and that range will come from adding and subtracting 6 to that mid parental height, sir. That will make a range for us, and so that determines the potential of that particular child, sir. The growth potential of that particular child.
Very good, very good. I will appreciate that you have come with this, I will say, good preparation. And that is the thing, please remember, not only for the exam, but even the practice, that having this figure, which will decide the range, plot on the growth chart, and even you can define that in any even child is going to have the target height in this range. And suppose now, if you see that if you draw the imaginary line from that particular, I will say, your reading, and that comes in that, I will say, range, probably you will consider that apparently less than that percentile. But I think for that family, for these parents, the child is appropriate, does not fall in the definition of the short stature. And what Madam said, unnecessary will not submit for the investigations. And we can explain even to the parents that this is a method. Apparently, you may be looking, child may be looking short, but I think if you go for this comparison of the family, which is a very important factor playing the role, and you can see on the growth chart, it is in this category, and this is targeted at least height, which is child is going to get it. And I'm sure that they will be convinced, right? So this is another method. Is there any other point to decide the short stature? One is the less than third percentile. Second point, what you said that check the mid-parental height and whether the child is falling in the range or out of the range. Is there any other point? Suppose I'm not able to decide on that particular visit how I will borrow the time to answer them. I'm giving some hint to you.
If it is in the
I think Dr. Harsh is
serial monitoring.
Yeah.
Yes, sir.
I think if you are sitting together, please use the one particular mode. Otherwise, there will be the echo. Okay. Nitisha, you can complete. Then we'll go to the next point. I think Anuj and so many other friends are there. Please take it.
Yes, sir. In the serial monitoring, if we do the serial monitoring, and if the growth of the height of the child falls below say 2 major centiles, then also we can consider it as a short stature, sir. If instead of 2 major centiles has gone lower, then we can go, or if the growth velocity or the height velocity become the age and gender as per if it is below 25th centile, then also we can consider it in a short stature, sir.
Fine. At least I will appreciate that you have the idea of some growth velocity, right? We'll try to understand from Dr. Shalvi. Now, let us ultimately come to this end that any child, when you feel or the parents has brought with this complaint of short stature, how perfectly we should define first. Then and then we can go further. Once we decide that yes, this child is short, then we'll go for further and how it to be decided. I think, madam, can you just, for the sake of students, can you just take
Yes.
it?
So any height of a child, if it is less than the third percentile, for the mid-parental height, the child is on the shorter side, or there is a faltering growth velocity. So say, as sir told, right, that right now the child's height is less than the third percentile, but even the parents are short. And when the projected height is in the target height, we can say. So what we tend to say is, we feel that at this point of time, if the child continues to grow like this, the child will fall in the target height. But the most important thing is to make sure that he continues to grow like this. And therefore, it is important for us to monitor the child's height for the next 3 to 6 months, get a proper growth velocity, right? And then I'll be more comfortably able to say that your child is doing fine and there's nothing to worry about the growth of your child.
So fantastic. I think as a general pediatrician, if you are knowing this exercise, I think nothing more is required. Because I'm sure rest of the things you'll be able to do regarding the history and points and even the investigations and category and everything. But most of the times in the practice, we observe that this is not defined properly, not worked up properly, and just will go randomly. So many investigations, many a times investigations are confusing us. I think that part later on we'll learn. But my first step was that this is the thing which we should be aware of it. I think next, even I would like to take the point before we go for the case. Then I'm sure that the case becomes easy for us if you have all these ideas. You know, we should know basic physiology. In any subject, it is said that first always try to know basically the embryology, then the anatomy, then the physiology, how this organ is functioning, and then organic damage, what is the pathology. And then we'll try to define that what type of pathology, and then we'll decide this at least some etiology. I think in any system, if you have this approach, let's always first define the anatomy, the second type of the pathology, and then at least try to get the etiology. I will say without the investigations. Investigations should be planned on this our thought process or analysis, our hypothesis, that what is the likely cause for this problem. And I'm sure that it works very well. For that reason, I think we should have the understanding of basics of the physiology. Therefore, let us try to understand what is the physiology of the growth. That means from the, I will say, conception or from the utero, how the child is growing. And what are the major factors playing the role for their growth pattern at different ages. You know, that will also give us the idea that a 6-year-old girl, what should I consider? Suppose this only 1-year-old child, what should come to my mind? And suppose 10, 12 years old, some boy or girl is brought with a short stature, what is the likely reason? And I'm sure with this understanding, again, it makes difference in our thought process. So with this idea, I think, let me go to some other names. Dr. Aditi, can you make your video on? Yes, thank you very much. Aditi, I hope that already we are discussing, you must have attended some part of it, although you joined late. But I think this is my first question. What is the normal growth pattern from this, I will say, in utero to this childhood or adolescence?
So the
Do you
growth
have any
model,
idea?
yes, a Karlberg's growth model is there, sir, which divides the growth into infantile, childhood, and pubertal growth patterns.
Very good, very good. I would be really happy that these students are knowing these basics. Very good. ICP model, what we say, right?
Yes.
Infancy, childhood, and puberty. Now, what is this concept? Can you take it in details?
Yes, sir. Sir, during infancy, the growth factors, insulin-like growth factors, they are majorly responsible for the growth, insulin-like growth factors. So in childhood, hormones, thyroxine and growth hormone plays. And so in puberty, the sex steroids come into play for the growth spurts.
Fantastic. And therefore, usually the history, what we should decide, that at to what age a child was growing where, and when the growth faltering started. That will give me the idea that during which period the growth is affected. And then I can decide, at least I can think that this is the likely factor or the category. Suppose what Dr. Aditi was talking, that after 3 to 5 years, mother says after 3 to 5 years, child was normal. And now significantly, as per our definition, child falls in the short stature. Then we'll think, oh, this is something probably hormonal disturbances, endocrinal problem is likely. Then you can go further workup. But suppose if it is a quite early phase, 1-year-old child, or even early, or even 2-year-old child, already what Dr. Aditi talked, probably endocrinal cause should not play the role. But all this our science is arbitrary lines. Not necessarily always it is compartment like that also we should keep in mind as a practitioner. I think as we grow, as we become the mature, we understand that everything what is said in Gita, we'll have to understand it exactly how we can take in the life. Similarly, in the medicine, they have given us all the guidelines, but not necessarily every child or every patient is following that compartment line. So that differences can be there. Sometimes an endocrine may start early, or even some other factors may play the role, nutrition even later on. But by and large, I think most of the times this time frame works. I think that we should do. And that is the reason that why we are describing, I may not go into details, but I'm sure that having this concept, that will give me some vision that how I take further for the thought process. Right. So I think for that, let us take the word from Dr. Shalini. Madam, can you take that, what is this, I will say, physiology of the growth and what factors are playing the role at different age groups, please?
Yes, sir. So I think a child will grow the fastest in the first 3 years of life, wherein the antenatal factors, the birth weight of the child, the maternal conditions, and the postnatal immediate nutrition also plays a very important role. So if there is growth failure in the first 3 years of life, those are the factors that we need to look after. Like when was the child born? What was the birth weight of the child? Was the child SGA, IUGR? Any risk factors were there which could cause the poor growth? And then normally we expect a catch-up growth to happen by the age of 3 years. So again, growth monitoring becomes very, very important. If by the age of 3 years, the catch-up growth has happened, which happens in about 85 to 90% of the kids, then no other further investigations or treatments are needed. After the age of 3 years, until they hit puberty, they will grow at a steady state of about 4 to 6 centimeters per year. So that is your normal growth velocity, wherein, as Aditi said, it is your growth hormone and your thyroxine, which are very, very important, right? And then once a child hits puberty, it is along with the growth hormone and thyroxine, your sex steroids, which come into play and give you your final height. Right. So whenever a disorder or whenever the onset of short stature happens, will tell us where exactly we have to look for in terms of our investigations also. Right. So if somebody comes to us at the age of 14 years with poor height, we need to look at puberty, whether puberty has started or not. If not, probably we have to pay more attention to puberty rather than going for growth and the other parameters. Right. So again, monitoring growth, I think that is the basic and that has to be done because that is going to give the clue to most of the scenarios. And when did the growth failure started? Again, if the child is too small to begin with, you're looking at something which is present since birth, so congenital. The child was growing fine and then the growth failure started happening. Something has happened later on. So it could be an acquired thing. Right? So again, the onset of growth failure can also tell us whether it could be congenital or acquired.
Yes, please.
Sir, is that okay?
Yeah, absolutely. I think she made our work very easy. Nitisha, what we are preparing, that having this understanding, I think our approach to the case should become easy for understanding, and I'm sure that that is the idea that why we are discussing. You know what we learned from this particular the discussion that sorry.
Nitisha, if I can just add one thing, right? When you said the
Yes, ma'am.
chief complaints, no? So you can always say that
Yes, ma'am.
there is complaints of not gaining adequate height since the age of 1 year, right? So
Okay,
just
ma'am.
the
Okay.
formation of the words, because when you're presenting a case in front of a teacher or maybe in the exams, these are the small words that will be caught on. So just make sure
Okay.
that that is happening. They also feel that the weight gain is poor. You have mentioned something like that. So again, the words, right?
Yes, ma'am.
Complaints of not gaining adequate weight. So it
Wait.
can be
Okay.
framed in that manner.
Yeah.
Okay, ma'am.
Like you have
Sorry
mentioned,
for
weight gain is also less. So you can say complaints of
Yes.
poor weight gain also, like something like that.
Okay.
Right? It
Okay.
doesn't have to be in exactly layman terms now.
yeah.
Okay, ma'am.
Sorry, sir.
I think one message which I would like to convey to all the students, anyone, those who are attending us, that growth chart is a priceless and valuable tool in our practice. Perform the habit. Any child, for whatever the problem it is brought, not necessarily shortage or some problem of growth, but even for the upper respiratory infection, viral or any issue, routine practice, always look at the growth, and therefore it should be plotted on the growth chart. I'm sure that once you perform this habit, which probably mother has not complained, we have not thought of, that will give some idea that something is wrong with the child. But not necessarily endocrine problem, I would say any systemic disorder or even some unusual conditions you'll be able to suspect and then you can confirm. So I think this is very important growth chart, and to utilize it, I will say regularly in our daily practice. It is a definitely very, rather than any sophisticated investigation, it is priceless, and I will say it is valuable. And I'm sure that this tool should be utilized properly. I think that's the thing which all of us can remember and translate in the practice. Okay, Dr. Nitisha, now you can take it further.
Okay, sir. Negative history. No history of poor appetite or pedal edema. No history of chronic diarrhea or oily stools. No history of polyuria, oliguria, polydipsia. No history of recurrent lower respiratory tract infections. No history of constipation, weight gain, dry skin, mental retardation. No history of bony deformity or recurrent fractures. No history of headache, vomiting, visual disturbances. No history of skin changes, hair changes, night blindness, bleeding gums. No history of obesity, stria, or moon face appearance. No history of short stature in parents, siblings, or relatives. No history of any chronic infection like TB, tuberculosis, and HIV.
Okay. I think again, can you just stop sharing? This is
Yes.
very crowded and lot many informations are there.
Okay, sir.
Actually, I have taken the shot of your point so that I can remember. I would say not only Nitisha should answer, but other students also. Aditi, can you come? Dr. Ravi, yes. Aditi, what negative points she has mentioned, what is the importance or relevant to our case? You have to give the explanation. First, she said poor appetite, pedal edema. What she wants.
Sir, to rule out malnutrition.
Okay, very good. Second point, she had mentioned chronic diarrhea and oily stool.
So history of malabsorption, like in celiac disease.
Okay. In
Cystic
celiac disease, will you get the oily stool? Suppose if you want to answer very specifically with the oily stool and even the diarrhea. child is not growing properly. Which condition she wants to at least exclude or rule it out?
So pancreatic insufficiency, cystic fibrosis.
Yeah, right. I think cystic fibrosis. I think regarding all this importance will come later on, but already what she had mentioned, let us try to understand. The third she had mentioned, no history of polyuria, oliguria, polydipsia.
So, polyuria, polydipsia, sir, diabetes insipidus can be one of the cause. Renal tubular acidosis, RTA.
Okay. She has mentioned oliguria also.
Chronic renal failure.
Okay. Can you give some illustration or some example where you will suspect highly that yes, this is likely the chronic renal disease? Child is brought to you, child is not growing or not gaining the height, he remains weak, and child is brought to you. Parents have no any other complaint. But what other features you may get on examination, which will make you to suspect highly that yes, likely the chronic renal disease?
So, presence of anemia,
Okay,
presence
very
of
good.
rickets changes, vitamin D
Yes,
deficiency.
very good. Anything on
Acidosis.
vitals? Anything on vitals?
Blood pressure,
Hypertension.
hypertension. On the
And
highest.
many times it happens, somebody ask me, yes, I have got even this situation. Not, I will say, so common, but occasionally, yes. That the child is quite pale, anemia. Maybe sometimes rickets is what you said, absolutely right. And majorly the blood pressure, hypertension. I'm sure that this will make you to suspect very strongly that likely this is some chronic renal disease and you will get it. I think as a clinician, we'll have to develop our vision. We'll have to find out some important clue, either in the history or examination or somewhere. That becomes a very strong point to suspect you. I think she has mentioned recurrent lower respiratory infection.
Cardiac conditions, cyanotic congenital heart diseases or congenital heart diseases can present with recurrent lower respiratory tract
You know,
infection.
Aditi, in a case of cyanotic heart disease,
and there will
the mother's chief complaint will not be the child is not growing. Chief complaint will be related to heart.
Yes.
Child is bluish. Right. Even for this short stature, probably it's not the complaint of the mother. You may notice on examination that, okay, child is not growing properly. But the chief complaint, that's why, onset of disease. What is the chief complaint? What is the chronology of the complaint? That also will give you the idea in the history. But okay, I think here she wanted to complete constipation, weight gain, dry skin, mental retardation. So many points I think Nitisha has added. What she wants to exclude.
So hypothyroidism.
Okay. And bony deformity and recurrent fractures.
Conditions like osteogenesis imperfecta or any skeletal dysplasias can be.
Okay, I think are you
also
final year student?
Yes.
When your examination date is declared?
January.
Okay, if not declared, ask even this Gujarat University that now take our exam earliest. We are prepared, well prepared. Fine, good. Anyway, headache, vomiting, visual disturbances. Nitisha, what was your idea?
Yes, sir. Headache, vomiting, visual disturbance. If we could be suspecting raised intracranial, raised intracranial tension.
Can you give some example where the raised pressure and short stature?
Sir, cranial, if it is a pituitary gland is involved and having craniopharyngioma, then also we can have this condition, sir.
Suppose I may take in some other way. It was not the craniopharyngioma, but following some disease, the child had developed the problem, endocrine.
Hypothyroidism, sir. Any hormone deficiency?
I will say intracranial problem.
Okay.
Pituitary problem. It was not, I will say, it is not even due to any tumor or so. That means which acquired disease can cause the pituitary, which may result in the endocrinal problem. Some student is answering, then examiner will find out some questions. I'm sure that probably might have not seen the patient, which we used to see occasionally in the past. But is there any CNS infection known which can cause the damage to the pituitary and may present with the endocrinal disorder, more I will say diabetes insipidus, or even the puberty problems?
Tuberculosis can be, sir. Histoplasmosis.
Very good. Even your tuberculous meningitis, we used to get it in the past. Few patients I remember. Later on, they come with the problem of puberty. And we realize, oh, this is tuberculous meningitis caused the damage to this pituitary gland. Anyway, so these are the few points which I would like to add to your learning. Suppose in the examination, you may have the good obesity stria. I think moon face, quite obvious, may not be difficult for you. Aditi, what you want to convey?
The Cushing-Gold features rule out.
Okay, even some chronic infection like tuberculosis and HIV. How many patients you have seen? I'm sure you must have seen the plenty patients of tuberculosis. And how many of them presented with a short stature? Might be written, I will say, the textbook. But being that I will say tropical pediatrician, suppose somebody is asking you that unfortunately we had the ample opportunity to see the tuberculosis. I will not say fortunately, but unfortunately. But yes, we do come across the tuberculosis, even CNS tuberculosis. But how many of them did you get even the short stature? Somehow it is mentioned in books, but hardly tuberculosis presents with a short stature. That too, even the extra, I would say, CNS problem. Occasionally CNS. That also, I will say, so rare. Anyway, what was my idea? One word, Dr. Nitisha, and even to all other students from the exam point of view. In any case, I'm not talking of this particular case. What negative points should be included? In the textbook, given the very long list, that every point should not be mentioned as a negative point in particularly your case.
Okay, sir.
In your case, you should find out these negative points. Which one? That suppose something your hypothesis, whatever you are considering, possibility. And concern to that something positive or negative, which is strengthening your possibility. Yes, that is should be mentioned. Similarly, second, that nearby differentials. Suppose here short stature. If you are supposed thinking for skeletal dysplasia, mention other skeletal conditions. Suppose some endocrinal, mention the nearby endocrinal disorders. But I will say nearby differentials, not the every cause of short stature. And third, what is the, I will say, known complication of that disease. Right. Suppose some chronic disease and that reflects even the rickets or even pathological fracture or something probably that you can make. That means known complication in that particular condition. And here you want to clarify that whether that complication is present or absent. So having this vision, you should find out the relevant negative points. That points concern to your possibility or your thought process, points related to the differentials, and points which are known for the complication of that condition. Right. I'm sure that if you try to put it, these negative points in this way, that will help you. And this is very important from the exam point of view. I think before we go further, let us take a word from Salmi Madam regarding the negative points pertaining to, I will say, endocrinal issues.
No, I think so. You're right. Like what we try to do is we try to screen system by system, which could be responsible for poor height gain, right? And therefore, we try to find out what symptoms should we ask for in the negative history. So I think you're right. So in the where you have mentioned chronic diarrhea, oily stool, sometimes they just may come with recurrent abdominal pain also. They can present as celiac disease. So that could also be included as one, because we usually do not see so many. So malabsorption will present more as failure to gain weight rather than failure to gain height. So all the systemic conditions, they present usually with complaints of poor weight gain. The condition progresses, continues without treatment, height is also affected. Right? So you have to primarily look at those conditions which affect the height first, because that is the chief complaint of the mother, not the weight. Weight is secondary right now. right? So again, just make sure that you're not writing unnecessary negative history.
Very good. Okay, Nitisha, you can take it further.
Yes.
I think you have done the good presentation.
Thank you, sir. Past history. History of multiple time admissions for hypoglycemic conversions. The first episode was seen at second day of life. History of taking oral levetiracetam 60 mg per kg per day from 2 years of age. History of taking injection growth hormone since 3 years, but no other medications. No history of blood transfusions. No history of tuberculosis infection or asthma.
Okay, I think you can complete the
Antenatal.
history. Then we'll come back.
Okay, sir. Antenatal history. It was a spontaneous pregnancy, booked pregnancy. Mother was immunized. Antenatal USG was suggestive of query IUGR as no documentations were available. This is as per the mother. Weight gain was 7 to 8 kgs. Quickening was well felt at 5th month. No history of gestational diabetes mellitus, pregnancy-induced hypertension, fever with rashes, or placenta previa. Natal and postnatal history. It was a full-term delivery. Birth weight was 1.7 kg. Birth length is not known. Mode of delivery was normal vaginal delivery. Presentation was breech. Baby cried soon after birth. There is history of neonatal hypoglycemic convulsions on second day of life. History of NICU admission for 5 days for low birth weight, IUGR, and hypoglycemic conversions. The diet history, the child was exclusively breastfed till 6 months of age. There is no history of mismanaged feeding. In the diet history, the child is a deficit by 300 calories per day, and in the protein 4 grams per day, the patient is in deficit. Developmental history, the child studies in first standard. The developmental quotient is normal, 85%. There is no issues with development other than language problem. Immunization history, vaccinated up to 5 years of age. Family history. This is a firstborn child born to a third degree consanguineous marriage. No history of significant illness in family. No history of chronic infection in family. No history of short stature in family. Father and mother attained puberty at normal age. Other siblings, a 4-year-old brother and a 2.5-year-old brother, apparently normal as per parents. Family belongs to upper lower socioeconomic status as per modified Kupuswamy scale. There is history of one episode of convulsion with fever at 4 years of age in father. This is the summary so far.
Okay, can you stop sharing?
Yes, sir.
I think history part you have completed.
Yes, sir.
I think first point, let me mention, I think I missed initially, which I intended to convey. Never reveal the identity of the patient by name or so, even in the exam or any place, right? Because that is very, very important. We should not reveal the identity by name or by even any other way.
Yes, sir. Okay.
Now, I think if you go in the details, let me go to other students. Aditi, Ravi, Dr. Jeel. I think let me go to other names. Dr. Jeel, are you there? I want to involve the students in the discussion. It should not be, I will say, monologue or dialogue with Dr. Nitisha or some comments from Madam only. Always participate in the discussion, and that will definitely enrich our knowledge or ideas. Let us forget regarding this rest of the history, Nitisha.
Yes,
But
sir.
any newborn with a history of hypoglycemia,
Yes, sir.
what will be your thoughts? And suppose with that short stature, let us take in this way, that there are the history of hypoglycemia during neonatal period, hospitalized or you have some documentation that is confirmed hypoglycemia. And now that 6 years or whatever the age child is brought to you for the short stature. Is there any link? Is there any association? Dr. Ravi, because Ravi has appeared. His video is on.
Is there any central cause? Like any pituitary lesions?
Ravi, I think there is some other phone is also on. If there are multiple modes, then echo
Yes,
will be
sir.
there. You can, I will say, switch off others and use only
Yes, sir.
one. Yeah.
Yes, sir.
Yes. I think my question is very clear and
Yes, sir.
answer should be so crystal clear. Is there any link between the history of neonatal hypoglycemia and the short stature later on presentation?
Sorry, any genetic cause? Yeah, central cause, most probably.
Like, can you give some examples?
Sir, for example, hypopituitarism.
Okay.
Or
How the hypopituitarism presents with the neonatal hypoglycemia?
sir, growth hormone deficiency. Due to multiple hormone deficiency, growth hormone deficiency can cause hypoglycemia, sir.
Okay, I think I will take it further. Suppose
Yes.
you thought of that this is probably having the link with the growth hormone problem. Then what
Yes,
other
sir.
features you will ask in the history, which will strengthen your possibility, that which will make you to consider that yes, now it is strong possibility. That means presence of other points, which you
Sir,
will verify.
IUGR, antenatal UAG suggestive of IUGR, maybe supporting.
Whether the IUGR is favoring your thought process of the growth hormone problem.
Yes, sir.
How?
Sir, is there any from since birth patient having growth retardation? So we can suspect that maybe any central cause.
On the contrary, if I remind you, I hope that Nitisha and others might have read that
Yes.
even the growth hormone deficiency children, how they present at the time of birth, suppose related to weight and other parameters, or even for the infancy, how commonly they have.
So they are normal at birth.
Mostly.
Yeah, Dr. Harsh had mentioned. On the contrary, commonly if you see that growth hormone really deficiency is an issue, and if you go back in the history, usually they are good at the time of birth. Weight may be even normal, not the IUGR baby, commonly. And second, even for early phase, even the infancy, because that's why I discuss appropriately ICP model. That initial infancy period should be unaffected, not the manifested, if the real growth hormone problem is there. I think common, that is our belief, right?
Yes.
So that means these factors should not play the role. If IUG, and here IUGR, how did that? We'll go back to madam. I think she will explain. But commonly what we are thinking, let us take one by one point, whatever actually Nitisha had given to us.
Yes.
And let us try to understand, and then we'll link each other, and then we'll try to understand that what is the likely disorder with this particular child. Commonly, if I say, and all of you will agree with me, that what we are learning, that usually growth hormone deficiency at the time of birth, baby is fine, normal, even weight is average or normal, and even good looking. Even for infancy also they are growing, not having any much manifestation, but later on, yes, they don't grow and falls in the category of the short stature, what we say childhood duration. And then with the further workup, we'll confirm, oh, it is a growth hormone deficiency. So here the issue was different. How it is, that we'll later on discuss. But the second point, so one question remained unanswered, that if you try to make the link between hypoglycemia and growth hormone deficiency, then what other points you will try to gather in the history, which may strengthen your possibility that yes, these are the favoring points. Which are the other points?
Microcephaly and flat face.
Microcephaly, why? Is the microcephaly due to the growth hormone deficiency? Probably no. Already we said that the
No,
baby
sir,
would
not
be
most probably
normal from the
any
growth point of view. Yeah.
genetic.
Anyway,
Genetic.
are there any other features which will manifest in the neonatal period which may have the link with the growth hormone? Yes, now Aditya is appear.
Sir,
Back.
mid-facial hypoplasia can be there. Sir, micropenis can be one point.
Yes. And something which is very common during neonatal period. Jaundice,
Neutral
Yes, sir.
jaundice.
right? Many times that undue, even exaggeration of physiological, which no reason. Later on, you will realize, oh, this was there, required the phototherapy. And you are thinking probably had what is my idea that after this knowledge, whatever we have read or idea, try to apply in one particular case. Are there any other features or points which is helping? I think here Nitisha said the jaundice was there. Am I right, Dr. Nitisha?
No, sir. Jaundice
No,
was
sir,
not
no
there.
jaundice.
Okay, no jaundice was there. Somehow I considered it. So this is one point. Second, but the hypoglycemia multiple times. She said on the contrary required the hospitalization. Is it a common feature with the growth hormone deficiency, Dr. Aditi? Favoring to your thought process or not favoring? What is your comment?
Hypoglycemia can be there in growth hormone deficiency. Sir, multiple
time.
episodes can, sir, cortisol associated hormone deficiencies can also be there.
Okay.
Um,
So that is number one. But now I will make even the first simple, then the confusing to the students to come out from that. Another point what Dr. Nitisha had mentioned, baby was intrauterine growth restricted. I think birth weight, what she said, 1.7. So whether this birth weight, on the contrary, if I ask you, let us forget regarding the endocrine, on the contrary, hypoglycemia is more common, frequent, recurrent, difficult even with IGR babies.
yes.
Right.
Sir, so I wanted to mention one
Yes,
thing.
yes,
There
yes,
have been
yes.
multiple times hypoglycemic episodes. So we need to find out what age the hypoglycemia happened. So whether it was in the neutral age only, that could be the IUGR induced, whether it was later on in
Later on
the
also.
after 6 months, after 1 year, then you can start suspecting your endocrine causes also.
Yeah.
Here we need to actually in detail what was the time of hypoglycemia.
Yeah.
Right? Usually growth hormone deficiency would be like an early onset hypoglycemia. So those parameters, those detailed history has to be mentioned for every hypoglycemic episode.
So
Then you
Nitisha,
may be able to find
yeah,
out.
Nitisha, you have the detailed information what madam wants? Because you said multiple times, but at what time, what age? And even I think you should.
Second day of life could be because of the IUGR, right? But then at what ages hypoglycemia happened, right? So say this child came to you with hypoglycemia. To find out the cause of hypoglycemia, you need to know that detail also.
Nitisha, you are muted. Unmute yourself.
Hello?
Yes.
Am I audible?
Yes,
Yes.
you are audible.
So as per the mother, there are not proper documentations available, but as per the mother, every 3 to 6 monthly, the patient gets one attack of hypoglycemic convergence.
Up to what age?
Even the mother is aware that every time, that is her chief complaint, that most of the times, whenever they get admitted, it is the sugar gets low, and that is why the patient gets conversion, and that is why they get admitted.
Yeah, but
this is as per the mother.
But Nitisha, you have any idea what madam wants, and I think her point is valid. That you have any idea with the frame of this age of the baby? First, probably okay, neonatal or second, third day, whatever it is. But later on, as you say, you have any idea that whether the 6 months, 1 year, later on, or what was the time? If you don't know, no problem. Answer very honest in the exam also that I don't know. I don't get the good answer.
Sir, this is as per the mother, sir. The documentations are not complete, sir. But as per the mother, the patient gets one episode every 3 to 6 monthly. There is one episode.
Okay. Anyway, I think now that point will later on go to madam. That how IGR and this hypoglycemia and the growth hormone, all the things to be considered and correlated. That will go later. I think before that, certain points we'll find out. You said the breach was also there, right? Breach presentation. Ravi, Aditi. What is the importance of this Aditi breach presentation? Is there any relationship with this growth hormone or endocrinal problem?
So breech delivery, sir, it is an epidemiological association that has been seen with growth hormone deficiencies.
How? How the breach plays the role? Any idea? I agree with you that it's a traditional, I would say, teaching or learning that a breach even is found one of the factor with even this growth hormone deficiency. How, I think we'll go to the melam if you don't know. But how this point is linked with the growth hormone. Yes, Ravi, what is your comment?
Trauma and breech delivery trauma, because of trauma maybe.
Okay, trauma to the
Level.
pituitary gland. Okay. And I think she mentioned there is no history of family history of short stature. Which conditions there may be the family history that multiple members are short? Are there any conditions?
Familiar short stature, sir.
Familiar short.
Okay. In a familiar short stature is different entity. Ultimately, they turn out to be one normal for that. But here, definitely short stature.
No, achondroplasia, sir.
Achondroplasia,
Okay. What type of disorder it is?
autosomal dominant.
Yeah, autosomal dominant. And therefore, in this type of situation, suppose multiple member, better to go for the pedigree. If you put in the pedigree, you will find out that what is the involvement of even the each generation, what even the how many people are male or female involvement, and that will give some picture from the pedigree. That it likely autosomal dominant disorder, autosomal recessive disorder, or some X-linked disorder, and that may give even some very on the contrary that becomes the important clue to reach the condition. So I think, and particularly here the consanguineous marriage you mentioned. So better to prepare this pedigree in these type of any disorder, not even endocrinal, as a bleeding disorder or any type of neurological disorder. If you go for the pedigree, many times you come to know, and I think it's very important nowadays because so many genetic disorders we are able to diagnose, at least to suspect from the pedigree, and then later on you can confirm. So this is very important. I think now, before we go further, let us take the so many points from Dr. Shalvi regarding IUGR and hypoglycemia and all the points, madam, please. And even the link with the breach.
Yes, sir. So I think the birth weight would be the most important, birth weight along with the gestational age, right? So that would be the most important parameter because we know that IUGR can be associated with short stature. It can cause hypoglycemia. A breech presentation can cause perinatal issues and can cause damage to the pituitary gland sometimes, which may cause later on a growth hormone deficiency, right? So again, association of hypoglycemias. So, sir, we do see sometimes patients exclusively in the childhood phase also who present to us with recurrent hypoglycemias and they turn out to have isolated growth hormone deficiency. So again, say you have a kid of hypoglycemia on the growth chart, you have short stature, I think that is shifted higher on the list and you have to investigate in terms of a growth hormone deficiency also. Right? There are various parameters now. We know that we need to monitor the sugar levels for all our IUGRs or preterm babies, periodically, at least until 24 to 48 hours to make sure that hypoglycemia and hypoglycemic brain damage does not happen. So I think, again, getting the history is very, very important. The time of hypoglycemia, whether it was related to prolonged fasting, any illness, or hypoglycemia just happens without any risk factor. So say you have a prolonged illness or the child has not eaten, you can suspect a ketotic hypoglycemia later on. But otherwise, a healthy child having frequent hypoglycemias, think of your endocrine causes also.
So I think so fantastic point have been derived in the history. Nitisha, I will definitely appreciate that lot many points you have derived in the history, and each point is very, very important for us to understand whether it is favoring, unfavoring, or suggesting any other condition. And I think we should know, even somebody may ask you that in a case of suppose short stature, nowadays, you know, the competency-based assessment in the exam, what the NMC has given the title. So they want the competency of the candidate from in the different fields, in the history, the examination, even for some procedure. And here in the competency in the history, what they want, that you should be aware that which points you should derive in the history, which is probably strengthening your possibility, or absence of that particular point, probably excluding that possibility. So I think both the ways, these are points you should know. Suppose somebody may ask you that what points in the history any child presented with a short stature, then what points in the history you will focus. And I think many points that Madam Salmi has mentioned that we should know starting from the antenatal history, right? Even the growth of the baby, intra-uterine growth. I think you know that this growth of the baby starts even the affection, even from utero, particularly nutrition point of view, after this, even the third trimester or mid-pregnancy or so. That will also become the very important information for us. Then particularly these at the time of birth, mode of delivery, starting from the breech presentation, or even this birth weight of the baby, even small for gestational age appropriate or even the large. Large baby is also definitely important, maybe even due to several reasons. Later on, even other reasons also in the history. Suppose somebody say, how the history of delayed passage of meconium will be important in this type of the case. There may be the history of delayed passage of meconium. Child is present with a short stature and other issues.
Sir, it may relate to hypothyroidism, may
Okay.
hint towards hypothyroidism.
Okay, and Aditi, beyond the endocrinal cause.
Cystic fibrosis.
Okay. Any other reason, Nitisha? Very good, because you are able to answer. That means my question is, what conditions as a clinician will keep in mind the delayed passage of meconium? Very good point. Endocrinal hypothyroidism, maybe even the cystic fibrosis, meconium ileus or delayed passage, or even, you know, sometimes Hirschsprung disease. Hirschsprung disease also will present with a delayed passage of, you know, what is my idea? That small point, but helps a lot for further process, further thought. And that is the point that how you should gather the data. First collection of data, put the data in the chronology or proper order, and then analyze them, and then try to derive some hypothesis of thoughts. I think this is the whole exercise in the medicine. It's a clinical medicine. And as you, I will say, good in this type of field, you become the good clinician. So I think for learning, we should have these ideas. And for the short stature, so many things, celiac and other things you have mentioned, so I may not go into details. But I think in the history, if I remind you, almost we have taken more than 1 hour, right? And this is the thing which I wish that any case, first you focus over the history. And now in the exam, Nitish, I know that all of you are preparing for the exam. Some teachers will ask you the summary after the history presentation. So I think let me go to others. Ravi and Aditi. 2 students will take them that go for the summary of this particular case from the history only. Ravi, are you there? Yeah.
Yes, sir. Yes.
Ravi, what I will suggest you, I hope you must be knowing, in the exam or anywhere, suppose the history summary should not be the repetition of the same points which already we have discussed. In the exam also, you know, the exam will discuss points. So on the contrary, summary from our discussion, what you have understood, what is your, I will say, inference, interpretation of all this discussion? What is your hypothesis? You know, I'm preparing some background from the history, that this is my thought process. Not necessarily one should be able to give the diagnosis. So in that way, summary should be very comprehensive. Only I would say short paragraph like 8 to 10 lines. Can you try? Make the attempt, please.
Yes, sir. Yes, sir. So a 6-year-old female child who was a third third degree consanguineous marriage are presented with poor height gain, sorry, a short stature, with the recurrent episodes of hypoglycemia since birth, and with antenatal USG also suggestive of IUGR, without any other systemic illness or any chronic infections, sir. The most we can comment it is a pathologically or physiological after we can examine the patient and anthropometry and growth charts. Right now, I can label it as a mostly short stature, according to patient not confirmed, poor height gain, with the recurrent episodes of hypoglycemia since, but without any chronic infection or systemic diseases.
Right. Okay, that is his way of putting the summary. Good. Aditi, can you make one more attempt in your own way? That how you will put in the exam? What you understood from this discussion? What is your hypothesis?
So, as per the history, sir, we can rule out the physiological short stature as there is no history of delayed puberty in parents. The parents are not short. So then, thinking of pathological, first we can rule out nutritional causes and systemic causes. So we are not getting any such history which are suggestive of ongoing chronic illnesses or systemic illnesses. So history of recurrent hypoglycemia, so it can be a pointer towards some endocrine pathology, some hormone deficiency. So patient has already been on injection growth hormones. So it is also a clue.
I think that is one point again which I wanted to mention, but I miss it, Dr. Nitisha. Never mention the particular diagnosis or even the treatment. On the contrary, you can put in some other way. That consulted by some specialist person, or some workup was done and advice for daily injection. On the contrary, somebody will ask you the question in this way also. Can you presume that what treatment is likely going on? Or in other way, Ravi, which treatment likely going on in various, I will say, modes of treatment, where it is in the form of the daily injection?
Sorry, sir.
Which conditions? Here already one Nitisha had mentioned.
Sir, already she is taking growth hormone injection, sir.
Any other condition where the child is getting daily injection?
So daily injection. Diabetes type 1.
Yeah.
Insulin.
Any other thing? This is the thing that how they want to assess your ideas. Suppose somebody says, how will you confirm the child is daily getting the iron? You have started the iron therapy in a case of anemia. How will you gather the information from the parents or even the patient older one that yes, iron is going on?
Sir, any dilution factor, giving through IV route or dilution?
Not injection, I'm talking of oral iron.
Sir, oral, if they are
but
taking...
I want to check the compliance.
Yes, sir. They are taking with the lemon, early morning mandatory with lemon with for absorption for vitamin C.
Usage of black colored stools.
Yeah, that's right.
Staining of teeth, black colored.
I will just ask even look at the teeth even. I will not ask even. But not necessary. Many times on the contrary, we advise to avoid the staining, that directly they should put it even the pharynx and swallow. But black colored stone, even the similarly, that the red color or even the orange color in a case of rifampicin.
Yes, metronidazole and rifampicin.
Yeah, even pyridium, suppose going on some color of the urine. What was my idea? That examiner wants to know to make it a good clinician. That how will you gather the information? So here on the contrary, Nitisha, what you should make it, I will say, rather than putting the growth hormone or something, that later on child is on some daily injection. Rather than putting I will say, suggesting or mentioning the name of this growth hormone also. Anyway, I think how better we can try to put this summary. Let me even give some ideas. Number one, always focus over the information what you have. Negative points already probably we have discussed and exploded. I built up my story on the information which is available to me. And on that information, I will prepare the hypothesis that what is the likely problem. And with that problem, even you can say that what is expected on examination. Many times examiner asks the next question also, that before examination, tell me that what you are going to get on the examination or what very specific points you will check it. This type of question also people are going to ask. That means what is your thought process is clear. I think here we can put it that the 6-year-old female is brought to me by the mother with the complaint that the child is not gaining the height. On details of information, I came to know that during antenatal period, mother had no any problem, but somehow during sonographically, mother was informed that baby is not growing well or not gaining the weight according to expectations. At the time of birth, it was breech presentation with even the intrauterine growth restriction. Later on, the baby developed the hypoglycemia. As per the information provided by mother, it was multiple times at different ages. And even this, it was later on, somehow mother noticed that from the early infancy, child was not growing well. On particular details of history, I came to know that most of the other systemic disorders are not likely in my consideration. Having this background, I will focus over the endocrinal problem. Of course, I verified even the history of jaundice and macropericellin. They are not available, but still I will consider that likely the endocrinal problem is from the growth hormone deficiency or something. I think you can put it very positively, and most of the examiners will consider us. Dr. Salmi, should we go for examination or any comment from your side?
Just one thing, sir, when
Yes,
we're
sir,
looking
please.
at the developmental history, it's important to
Yeah.
mention about dentition because that gives an indirect idea about the bone age also. So when did
Absolutely.
the primary dentition started? She's already 6 years. So secondary dentition has started or not. And we should not say that, like when we are doing the summary, like one of the guys mentioned that the child presented with short stature. So short stature is a diagnosis that we make, right? Based on the information. The child came with poor gain of height or inadequate height gain, like just when they present the chief complaints. Yes,
absolutely, sir. Absolutely. I hope that if you get the short case in the exam, MD exam, you know, short stature may be the short case. But I think the short case should become the long case in your discussion. And then I'm sure that you are going to get the good scoring. Fine. Nitisha, you can take it further, the examination points.
Yes, sir. The child is conscious and alert. Mild.
Nitisha, I think if there is some net issue, multiple interruption, you can make your video off so that your voice will be clear and it will be uninterrupted.
Okay, sir. Okay, sir. General examination, child is conscious.
Nitisha, can you make it full
Yes,
screen?
sir.
Full screen.
Yes, yes, sir. Okay.
Yes, fine, good.
Sir, general examination, child is conscious and alert. Mild pallor is present. No icterus, cyanosis, clubbing, lymphadenopathy, edema. Temperature 98 degree Fahrenheit as per measured in the axilla. Heart rate 110 per minute, respiratory rate 20 per minute, blood pressure 98 by 60 mmHg, which is falling between 58 to 98 percentile. SpO2 is 97% on room air, sir, and RBS is 45 milligram per deciliter. In the anthropometry, the weight is 15.5 kg, expected is 20.2 kg for this age and gender. Percentile, it falls in the 10th to 25th percentile. The height is 92 centimeter. Expected height for this child is 115.1 centimeter, which is less than third centile. BMI is 18.3 kilogram per meter square. Upper segment length is 47 centimeter. Lower segment is 45 centimeter. Upper segment to lower segment ratio is 1.1 and arm span is 88 centimeter. The child's height is 92 centimeter. The father's height is 1 centimeter. Mother's height is 155 centimeter. The mid-parental height is calculated to be 156 centimeter, which is falls between 25th and 50th centile. The target height range is 150 to 162 centimeter. The interpretation, the height age of this patient is 2.5 years, weight is 4 years, chronological age is 6 years, bone age is 1 to 3 years, height velocity is 3.2 centimeter per year. Bone age is less than height age, which is lesser than weight age, and which is lesser than chronological age. This is the growth chart of that patient.
Nitisha, if you can just tell me how you calculated the growth velocity, because this was the child that came to you at the age of 6 years.
Yeah.
We have mentioned the
Yes.
growth velocity, and
Yes, ma'am.
it is the examinations. We've already done the bone age, like that would be a part of the investigations.
Okay. Ma'am, the height velocity, because there were some documentations available which had from the previous admission, which had one documentation of her last height, which was taken in June 2023, ma'am. It was around 88 centimeter, ma'am, and the current height is 92 centimeter. So I applied the formula, ma'am. I subtracted 92 minus 88, and since 15 months had passed since then I divided by 15, and then to calculate the per year velocity. So that is how it came out to be 2
So
centimeter.
you can just mention that height at the age of, say, 4 years and 9 months was 88 centimeters.
Okay.
So just mention in
Okay,
that
okay, ma'am.
anthropometrical list also,
Okay,
because otherwise
okay,
people would
okay.
feel that where did you get this figure? Right? And the
Okay,
bone age
okay,
would be a
sure,
part
ma'am.
of the investigations.
Oh, okay, ma'am. Okay. This is the growth chart. At 6 years of age, the weight is 15.5 kg. It is falling between 10 to 25th centile. And the height is 92 centimeter, which is lower than third centile. In the above part, I have plotted the mid-parental height and the target height range in black color, which is 150 to 162 centimeter.
Nitisha, you have plotted the growth velocity chart, right, at 6 years.
Yes,
So
ma'am.
growth velocity marking has to be done in between of the two measurements.
Okay, ma'am.
Right, because it is over that period of time that was the growth velocity.
Okay, ma'am.
Right, so maybe somewhere at 5 years, 3 months. Because you have one measurement 15 months back. And it would be worthwhile to plot that earlier measurement on the growth chart also to show the growth failure.
Okay.
Sorry, sir.
Isha, can you take it further? Isha.
Hello, sir.
Nitisha, you're audible. You can proceed.
Yeah, I think you can proceed.
Okay.
Yeah. Continue.
In the head-to-toe examination, frontal bossing is present. The eyes are normal. Fundus.
Your slide is not moving. It shows the growth chart.
Okay. Yes, sir.
Okay. Can you go to the next? Already you
Yes,
discussed this slide.
Yes, sir. Head-to-toe examination.
It is not seen on my screen.
Oh, okay, sir.
Yeah, now it has come. Yes.
Okay, sir. Head-to-toe examination. Frontal bossing is present. Eyes are normal. In the fundus, there is no papilloedema. Nose is flat with depressed nasal bridge. Ears are normal. Voice pitch is normal. In the dentition, there is no crowding of teeth. Oral cavity is normal. No midline defects. No webbing of neck. Shape of chest is normal. No skeletal anomalies. No kyphoscoliosis. No obesity. Forearms, arms, and hands are normal. Skin is normal. Hair are thin. Nails are normal. No asymmetry of body. And external genitalia, as per Tanner staging, SMR grade 1. CNS examination, the child is conscious, oriented to time-based and person. Pain and nerves are normal. Motor system tone is normal. Power is 5/5 in all 4 limbs. Reflexes are normal. Superficial and deep tendon reflex is normal. Plantar bilateral flexion is there. Coordination of the movements is normal. No involuntary movement is there. Sensations are normal. No cerebellar sign. No signs of meningeal irritation. And skull and spine are normal. In the cardiovascular system, heart sounds are normal, normal present, no murmur is there. Respiratory system is within normal limit, bilateral vesicular breath sounds with equal intensity. The abdomen is soft, non-tender with no organomegaly. In the summary.
Okay. Can you stop sharing?
Yes, sir.
I think first I request Madam Dr. Salvi to take details of the growth chart. And I think the exact of the chronological age and height, if it is as a whole, how they should do and how they should put it, even comparison, and how you can derive the inference from that. Can you take, I think, if you want, even she will be able to share that slide if you want.
Sir, you'll have to give me 2 minutes to just go, like, find out the PPT so I can share it.
Yeah, sure.
So if I'll just do that, sir. If you want to proceed, I'll just find out the PPT from my slides and I'll get back.
Okay. Meanwhile, I will take some other points. No problem. Okay. I think what is a very important point, Aditi, what should be mentioned in the examination point first in such patients? Shabi? Yes, Aditi.
Yes, sir.
I hope that you are on duty or some other work and in between disappears and then again comes. Is it so? Or are you constantly available?
No, sir. I am listening, sir.
Nice. I think very important in such patients, the first comment on starting the general examination. Usually what we do, that make some comment on nutrition, build, or even appearance of the child, is a sick looking, good looking, right? Irritable, lethargy, something like that. All these general comments that would be very useful, which will be even linked with the disease process. Similarly, in this type of the case, where the short stature or something your endocrinal issue discussing, what very important, I will say, your comment on the general examination. Always mention regarding the dysmorphism.
Dysmorphism.
Right. Or any chromosomal or some syndromic condition. And that with this, most of the times they are having some dysmorphism. Even in such patients, suppose if I say no dysmorphism, that means, the whole group I excluded. That less likely in my differential diagnosis. That's the thing, that how we come to the conclusion. Okay, so this is very, very important point. I think upper segment, lower segment, again, sometimes it will be very important that somebody will take the time for the discussion. How will you measure? Probably we'll not go into the details, but I want to draw your attention that somebody will ask in the exam that demonstrate how will you measure the upper segment, then the lower segment, and how will you calculate it. So that's very important point. And then even this proportion of the arm span and something. Suppose usually what is the relationship in height and arm span? In a, I would say, grown-up person or adult? In a normal person?
Arm span is more than the height, sir, in an adult, sir.
Okay, is it?
And
Nitisha?
No, sir.
Okay. This is my job.
Height.
That in the
Height is more
students,
than
when
the
they are
arm
in the,
span.
they are having the competition. Harsh, what is your comment? Because you said it's not right.
Sir, height is more than the arm span is more than the height. That is likely to be Klinefelter or any other animal as well. Arm span is more than the height.
I think another thing which I will say, never fix up your mind for the condition.
Okay.
First, decide what is this exact measurement and then proportion. I think your point is valid that the adult, usually height is more than the arm span. And some difference of 4 or 5 centimeter is going to be there. But suppose really arms are more, that means longer upper extremities. What is the likely cause? I think now, Harsh, you mentioned some of the conditions.
In Klinefelter, there is arm
Okay.
span is more than the height. In the
Right? Any other condition?
Marfan syndrome.
Marfan syndrome.
Marfan syndrome, very good.
Marfan.
One more, even any metabolic disorder.
Homocystinuria.
Very good. Homosexual. And suppose person is normal. Nothing is there. Then what do you call it? What I mean to say physiological. Person is normal. Just this extremity, upper extremities are longer. And you know, it is said that in the standing position, the tip of the middle finger, if it goes beyond the knee or even up to the knee, it is said that the upper extremities are longer. And some normal persons can have it. What do you call, any idea in Gujarati or Hindi? Yes, Ravi?
Ajan Bahu.
Oh,
Ajan Bahu.
Who said? Very good. It's Ajahn Bahu. And who was the Ajahn Bahu? I would say great person
Sri
of this
Ram.
country. Of this country.
Previously gods are all Ajan Bahu, Ramakrishna.
Okay, I think rather than Dev Devi, I will go to the real person of this
Gandhi.
country.
Mahatma
Great
Gandhi.
Kali.
Mahatma Gandhi was having not the Ajahn Bahu.
The great Kali wrestler.
No. This may be the question of general question, but I think we should know. And you know, in the Shastras, it is said that Ajahn Bahu is usually intelligent or even the lucky person. It is said, I don't know if it is right or wrong, but they say. And Ajahn Bahu, you know, our first Prime Minister Pandit Nehru was Ajahn Bahu. If you see his photographs, even old ones, when he's walking, he's even upper extremities just touching the knee or beyond. I think most famous photograph, if you see with Mr. Kennedy, very nicely his photographs are seen, and that is Ajahn Bahu. Anyway, I think this is just may not be the important in the endocrinology. Shalmi may consider that, but I am sure that it's worth to know what is it. Then what is this frontal bossing? What does it indicate? Frontal bossing due to what? Come on, Nitisha, you have mentioned.
Yes, sir. Sir, frontal bossing is one of the signs of hypopituitarism, one sign suggestive for hypopituitarism. May also suggest rickets, sir, and any hemolytic anemia, any cause of hemolytic anemia.
Suppose if you explain how the hypopituitarism, what is that? I think the kids understood. Hemolytic anemia, yes. But how it happens in a case of hypopituitarism? Any idea or any explanation?
I
don't think so, and something is there, Madam Salvi will take it. Another point, never mention the contradict findings in your presentation. Nitisha, you said, when you showed in the growth chart that weight is less, and now you say no obesity. I think it is already made the obvious, right? This is little bit contradicting yourself. Or in other way, I will say, it's not important to mention the no obesity because you have made the point clear that there is no question of obesity, right? So I think, to make the impressive, lucid presentation, even select the appropriate points and even words, proper even English, so that, it convey the exact meaning and it becomes the impressive, I will say, presentation. You have done, I will say, very good, but to make it even still better, I will suggest some of the points, and I'm sure it will be useful to all of you in the exam. I think Madam Shalmi has got her presentation. Let us try to understand the exact utilization of the growth chart and its interpretation.
And sir, one more point, when we mention SMR1, we usually say it is B1, B1, P1, A1, not SMR1.
Yeah.
So we have to individually mention all the parameters as one, like that way.
I think one more point I will take for the example, because I'm preparing these soldiers for exam.
Yes,
that for the undergraduate students, if they say SMR, I'll be happy.
Okay.
Oh, he knows the SMR. And then 1, 2, 3, something he speaks, okay. But postgraduate will be very precise. And therefore, our precision should be reflected in our presentation. Anyway, I would say in your presentation, suppose Glasgow Coma Scale, SMR, or whenever you are putting this type of this thing, rather than putting the Glasgow Coma Scale 10, you would say EVM, what is that? Similarly here, sexual maturation rate, rather than putting it, put even the exact components. And that is also important, that which one is added, even the ahead to this. And that will also may be the important point to note it. So I think very good point, Madam, has taken. Dr. Salmi, you can take it further, please.
Sir, I'll just quickly go through this because
Yes,
it is otherwise slightly longer.
Anyway, I think you can make comprehensive because we have the time limit
Yeah,
also.
I'll just, so I think everybody knows why we need to use the growth charts and what the different types of growth charts are available. We also have the disease-specific growth charts. So for our kids of Turner syndrome, achondroplasia, Prader-Willi syndrome, even now we have the SGA growth charts also available. So it is advisable for us to use the growth charts. Now, when we talk about the growth charts, one basic thing to remember is blue is always for the boys, pink is always for the girls. On the x-axis, we have age in years. On the y-axis, whatever parameter we are testing. So in the upper portion, it is the height in centimeters, and the lower portion is the weight in the kgs, right? So that the x-axis is always age in years, or in the smaller growth charts, age in months, right? And these are the WHO growth charts, 0 to 5 years, which has head circumference as another parameter. Right? And these are the preterm growth charts that can be used, the Turner syndrome growth charts, and the pediatrician-friendly growth charts which you have put here right now, which has a small BMI section on the left top and a MPH calculator on the right-hand side. Right? So this is the BMI section, and this is okay. But as sir mentioned, the most important thing would be to start using growth charts, not only when a kid comes to you with complaints of poor growth, but ideally in all the circumstances. So you're treating a kid of nephrotic syndrome, the disease is well controlled, the steroid side effects are not there, then that will be reflected on the good growth on the good growth chart, right? So very important for you to use the growth charts. So these are the basics of a growth chart. As I said, x-axis in years, it has got 12 columns, so one column for every month. And y-axis is whatever change in reference we are measuring, that is going to happen. And this is how we'll be exactly monitoring, measuring the height. So 4 points to remember, right? The occiput, the shoulder blades, the bums, and the heels should be in contact with the vertical surface, and the eyes, the Frankfurt plane, right? So that also has to be mentioned. Sometimes the kids will come with a ponytail on top of them. So make sure you're removing the ponytail before you're measuring the height. If they're wearing slippers, ask them to remove their footwear also before you check the height. And preferably be done by the same person. So inter-observer variability is not there. So how do we plot out the growth chart? First important thing is to measure the height and the weight accurately, select the appropriate growth chart, and then again, very important, just put a small dot, do not circle it, right? Because then you'll be occupying the next quarter or the 6 months on the growth chart also. So for example, this is a 7-year-old girl whose height is 119 centimeter, the weight is 21 kg. So small dot at the respective parameters, and we're going to use a pink colored growth chart for this. So then what we do is we calculate the height and the weight percentile, right? So this gives you a rough reference on what the child's growth parameter is as compared to the population, right? So this child is on the 50th percentile for the height and the weight also. Then what we do is calculate the mid-parental height. So we do not just compare the height and like height of a child according to the population, but we need to compare according to the genetic potential also. So you have all correctly mentioned the formula. For the boys, plus 13/2. For the girls, minus 13/2. So in this case, this is the MPH. And what we do is, at the age of 18 years, we just put a small arrow and then we calculate the target height. We know nothing is perfect, right? Everything has a range. So plus minus 6.5 centimeters on both the sides gives you the target range. And this is how you plot on the growth chart. So ideally, the child's growth should fall in this target range for it to be normal. So what we do is we construct the third percentile. Like your child was on the third, less than the third percentile. So this is also somebody like this. So what we do is, this is the target height. The lower border of the target height, you plot the line like this, an imaginary line. And that becomes the third percentile for this family, right? So though the child looks below the third percentile, the child looks very much in the normal target range for this family, which is all on the shorter side. So this is how you calculate the third percentile for the family, right? I hope everybody is clear. If you have any doubt, just put in the chat box. I'm going a little bit faster. Very, very important to monitor growth velocity, because we know that conditions which are physiological, like constitutional delay or familial short stature, will have a normal growth velocity. But if there is a pathological condition, there is growth failure, and therefore the growth velocity is affected. So that is change in height upon change in time in years. So say after 6 months, the child is 121. It was earlier 118. So the child has grown 6 centimeters per year, which is a normal growth velocity. So you can see that if the child continues to grow like this, the child falls very well into the target height. And therefore, though the child looks short, the child is otherwise perfectly normal and no further investigations may be done. So these are the growth velocity charts for the girls and the boys. Just a quick note, if you can see, the growth spurt in the boys happens a little later, right? And if you can see, it is quite peaked also. If you look at the girls' height velocity charts, the spurts start happening in B2. So the spurt happens earlier, and therefore, once they have their periods, they would finish their growth also, right? So this is, this child's growth velocity was 6 centimeters per year, right? So what we did is, we plotted in between the two height measurements, and that is on the 75th percentile. So any growth velocity less than the 25th percentile, here we do not consider the third and the 10th. Height velocity should be 25th or more than the 25th percentile, then that is normal. Again, remember, anybody growing at a rapid growth velocity before, like in the peripubertal age group or prepubertal age group, always suspect precocious puberty, right? Then what we do is we calculate the height age and the weightage. Again, very, very important. So Nitisha, you should have just plotted on the growth chart and shown on the growth chart also what we mean by the height age and the weightage, because then we know that if both the parameters are on the lower side, which parameter is more affected. And therefore, we know what kind of investigation to go for, right? So here in this child, so what we saw is the child is 10 years, 9 months. Height is 126. Weight is 20. So both the parameters are on the third or less than third. But when we look at the height age and the weightage, right, what we see is that weight is the parameter more affected, right? Height is less affected. So you can, like, the child is thin and short, and therefore those investigations can go accordingly. So I hope everybody is clear on the plotting of the growth charts. On the use of growth velocity charts, you may not use the growth velocity charts, just measure the growth velocity. You should know what the normal growth velocities should be like and what are the Tanner stagings. Sir, I think this is okay.
Okay, I think you made the point very clear, very clear.
Yes, sir.
I have listened, Dr. Salvi, I will say at multiple occasions regarding discussion of the growth chart, and very, very important. And I think she's very clear. I think I may request that even for the sake of student, you may put even your presentation in this group, or even probably we can arrange at some time that we can spare some half an hour or so. And I'm sure, but this is to emphasize the importance of growth chart. After the plotting, I think how to interpret even the various chronology, age, height, age, weight age, how to compare and to because it defines the exact category, and from that category you can understand that what is likely disorder. So that very precise investigations you can ask for, and you can confirm or exclude the condition. And I think that exercise works very well. So that is very, very important. But I think my question with the growth chart related, Dr. Nitisha or Ravi, Aditi, why the growth chart is blue for the boys and pink for the girls? There are different types of the examiners. Some examiners will ask the very, I will say, academic questions. Some examiners will assess whether you are aware of the general points or not. Why it is so that the blue color selected for boys, pink color for these girls? Any idea? Any stories there, or just selected somebody? Nitisha, Aditi?
Yes.
Do you have any idea? I think girls should have the idea. That's why I'm asking. That is also the old story that long back, that was the selection of the color with the gender. Almost, I will say, some hundreds of years back, that blue color for boys and pink color for girls. And even some French countries and others, they had some different reasons, but the selection was like this. And then CDC in 2000 decided that it should be applied in the growth chart also. And therefore, since I will say almost 2000, the growth chart color coding is there. So somebody suppose they ask, at least you should be aware of it. Anyway, I think your presentation examination is over, Dr. Aditi.
Yes.
You have some investigations?
Yes, sir.
I think you can share the investigations, and I request Dr. Salmi to focus on the investigation for his interpretation, because she is the right person.
Original clinical proportionate pathology procedure, and we have at least.
Nitisha, your presentation is not seen.
Okay, sir.
Just it comes that Nitisha has started screening.
Sir, visible now, sir?
Yeah, now visible. You can take it further. Yes, please.
Okay, sir. So the investigations, there are certain levels to the investigation, sir. Firstly, level 1, CBC is suggestive of microcytic hypochromic anemia. ESR is normal, RFT, LFT, serum calcium, serum phosphorus are normal. Urine and stool routine analysis is normal. Bone age is 1 to 3 years. Level 2, karyotyping was done. It was normal. Thyroid function test was normal. In level 3 investigations, TTG, tissue transglutaminase IgA and IgG were normal. Growth hormone stimulation test and MRI brain were done. This is the results of our investigation, sir. Clonidine stimulation test. As the growth, the raise in the growth hormone is less than 10 nanogram per ml after the stimulation of clonidine. Therefore, we can conclude that growth hormone deficiency is present. And in the MRI brain, it was suggestive of pituitary interruption syndrome because of hypoplastic anterior pituitary gland, ectopic posterior median eminence, and non-visualization of the stalk. These are the investigations.
Right. Okay. Anything else?
Anything else? Just treatment, sir. This is the last slide.
I think that part you can stop. We'll discuss with Madam.
So Nitisha, can you go to the investigations level 1?
Yes,
so where
ma'am,
you have
sure.
mentioned the bone age of 2 to 3 years, right? So now we have got lot of online tools also which are available.
Yes,
Sorry, you have mentioned 1 to 3 years, right? So
yes,
for a 6-year-old, if the bone age is 1 year, whether the bone age is 2 years or 3 years, that matters a lot, right?
Yeah.
So you can start using those online tools which are available, which can help you to narrow down the bone age. We're not asking you to give a perfect bone age, but narrowing down the bone age is very important. In the level 2 investigations, you cannot say karyotype NAD. You have to say 46XX.
Yes.
Right? Because
okay. Sorry, ma'am. Okay.
So in a short stature kid, especially a girl, Turner syndrome, ruling out Turner syndrome is very
Yes, ma'am. Yes,
we know that mosaic Turner can come to you just with short stature, right? So again, sometimes we might want to mention how many cells have been studied. Right? I mean, just for your reference, because sometimes we do ask for, 50 to 100 cells to be studied, so we don't miss the mosaicism. Just to the normal thing. Another thing, whenever you're suspecting a growth hormone deficiency, as you are in this kid, again, mention the levels of TSH and T4. You cannot say normal, because the second thing that you start thinking is, does this child have anything else other than a growth hormone deficiency too? Right? So a slightly, say, normal TSH with a low T4 can point to a central hypothyroidism, right? So always mention TSH value, always mention your T4 value. Right? The most important question I want to ask is, the child is already on growth hormone since the age of 3 years. Then what is the point of doing a growth hormone stimulation now? Like, were you just trying to, why was the growth hormone started at 3 years? Was the child not evaluated at that time? Straight away growth hormone was started. What happened? Like, why did you do growth hormone stimulation now at 6 years?
No, ma'am, this was actually already done in the past. This is from 2020, ma'am, these investigations. This is
So then you
the
can mention,
case.
no, that this was done. Right? So otherwise you would think, right, why and what was the response to growth hormone therapy? The child is already on growth hormone since the age of 3 years. Is the child still short? So are you suspecting something else is happening also? The child is not responding. I mean, just for your information. Right? Height of the child is still on the lower side. Though the child is on growth hormone since 3 years. So that also should ask, no, why the growth of the child is not improving. Right? Another important investigation would be an IGF-1. Right? Because that is not used as a diagnostic tool, but as a
for the
monitoring tool.
Yes, ma'am.
Right? So you should mention that in your level 3 investigations also, where you want to get an IGF-1 done.
Ma'am.
Right?
Yes, ma'am.
And always, so again, in the examination, you said your sugar was 45 milligram per DL. Did you do anything about it? Like, did you do a critical sample? Did you find out, okay, why at the age of 6 years, the child still has a low sugar in spite of being on growth hormone treatment? So those things you have to ask. No? Right? So that means, does the child have any other? So here again, you have an MRI which shows a pituitary stalk interruption syndrome. So what about your ACTH and cortisol levels? So you have to remove the other pituitary hormones also. Right? So that hypoglycemia happened. Did it happen because of a cortisol deficiency?
Multiple pituitary problems.
Right? So again, when your posterior pituitary is affected, the child could have diabetes insipidus also. So you want to look at your sodium levels, whether there is hypernatremia or not. You want to look at your urine specific gravity levels, whether there is a very low specific gravity or not, which could point to a DIA. Right? So when you are suspecting, say you're doing the investigations, you have a child who has now proven growth hormone deficiency. The first thing before you put that child on growth hormone also would be to test for all the other pituitary hormones. So that if there are any other deficiencies, you need to correct them simultaneously. Right? So again, mentioning your TSH and FT4, because again, this could have central hypothyroidism. The child has not gotten better even after growth hormone treatment. So those things also you should start having those questions now. Yeah. Okay. Yeah.
Okay. Can you stop sharing?
Yes, sir.
I think last few minutes I can take from Dr. Salvi for the sake of student because so many, I would say, discussions are going on. Exactly this regarding the growth hormone deficiency, that how much it is common. Then second thing, particularly regarding the growth hormone itself, treatment therapy, that what are the exact indications at present at our setup, availability of hormone, and even its cost and something, because I'm sure that this is also very important for the general pediatricians to know. We have the 5 minutes, but I'm sure that you can take it in short.
Yes, sir. So I think again, even if a child comes to us with complaints of poor height, again, we still follow the growth charts. We do the growth monitoring, make sure. So again, growth monitoring helps us because if you put a child on growth hormone, if you have the pre-treatment growth velocity, you know whether the child has improved on growth hormone treatment or not. Right? So again, monitor the child for 3 to 6 months before you do all these investigations. That is very important. If you get a sugar of 45, that would be a good opportunity to get a critical sample. Then you may not need to do the growth hormone testing and your cortisol levels also, right? So if you have a frank hypoglycemia, with the child had so many episodes in the past, doing a critical sample at that point of time would also be very, very important. Now that you have proven that, say, this child has just a growth hormone deficiency at this point of time, the cortisol, the other pituitary hormones are levels are normal, you will be putting this kid on growth hormone treatment. It is available as either a daily subcutaneous injection, or now even a weekly, once a week growth hormone therapy is also available. The weekly once a week growth hormone therapy is approved only for growth hormone deficiency at this point of time. But the daily growth hormone therapy has got various indications. So starting from a growth hormone deficiency, which can be congenital or acquired, Turner syndrome, kids of chronic renal diseases, right? So we have got so many of our kids of chronic kidney diseases. Pre-transplant, we put them on growth hormone treatment so that after transplant, the height benefit is quite good. All your SGAs or IUGR babies or preterm babies who have got a failure to catch up. So by the age of 3 and 4, we expect them to have a catch up. But if they have got a failure to catch up, then also growth hormone therapy is indicated in those patients. Idiopathic short stature, so you have investigated everything, but still the child is on the shorter side, growth hormone therapy can be offered to them. Both familial short stature and constitutional delay are now a part of it. Your syndromes, right? Your Prader-Willi syndrome, wherein you give growth hormone for the metabolic benefits, your Russell-Silver syndrome, right? So those are other few indications where growth hormone therapy is approved. By and large, growth hormone therapy is a very safe and effective medications, right? So again, improvement in the growth velocity on the growth chart is the best parameter to monitor somebody on growth hormone therapy also. But if somebody does not respond to your growth hormone therapy, make sure you're ruling out you're finding and looking out for the other causes also. At the same time, if on the bone age, all the epiphyses have fused, then growth hormone therapy is not going to work, right? So if somebody comes to you, say after periods of 1 year, where all the epiphyses have fused, then there is no point in giving growth hormone treatment, right? So proper indication, growth hormone is going to work wonders. Yes, sir.
Thank you very much. I think you made the several points very clear. Very important, many times I would say the practice what I observe. That suppose once you are suspecting growth hormone deficiency or so, I would say rather than to go for the stimulation test by your own, many times, what happens that this test is misguiding. If it is not done at proper place, proper laboratory, the person who is, I will say, fully aware, and even the proper stimulant agent also which you are using and observing. Because, many times what happens that the growth hormone, all of us know, it's a pulsatile physiologically. And then many a times if it is done at particular time, which may show the deficiency, even in a normal person, or many times with the deficiency even may show normal levels. So the point is probably your interpretation may not be right. And therefore, usually suppose personally if I talk, as a general pediatrician, I suspect suppose growth hormone deficiency, I stop myself. I take the help of this, even the endocrinologist, that is it right what I'm thinking? And suppose the person says yes, then let the person decide at appropriate, I will say, setup with even the proper laboratory, because every laboratory cannot do, and that is not their fault. And then many times I have seen the fallacies and the lot many issues. So I think that is also important for all of us to know that the proper testing, proper place, and proper interpretation, then to start this appropriate treatment is also very, very important. And I'm sure that whatever in the 2 hours we should do, we have tried our best. And let me tell that, Titisha, you selected the very good case. Selection of case, I'm
Thank you,
sure it was very good. Even you, I will say, prepared the good presentation with lot many informations. Of course, what Dr. Salvi suggested, if you take it even, and if you still improve, it is going to be the, I would say, impressive presentation. And I appreciate your colleagues also, even Ravi, Aditi, and some of your colleagues, those who participated, even very actively. I can make out that your, I will say, preparations for exam is definitely good from this one of the presentation and participation. It looks And I'm sure that you'll be able to do still in a better way. The only thing that always continue to learn. It is said that even whatever our capacity or capability, but once you stop to learn, then probably due course of time, automatically we are out of the course. It should not happen. And therefore, I think remember Dr. Ambedkar's one sentence that if you do it, probably you are living but academically dead. So I think we should not go for that. Academically, we should be, I will say, alive at every moment. And that keeps us, I will say, always updated in the subject. I'm sure that you will keep in mind this thing, not only for the exam, but beyond that also. Here we'll have to end. I hope that whether Dr. Nehal is there. And of course, presence of Dr. Salvi made the difference of our understanding, interpretation, how to put it, even the growth chart, how to, I remember one of my students long back, 20 years back, Dr. Ramnathan, who was in LG, very good, I would say, as a resident. Last year he came in Ahmedabad and met me. He's endocrinologist in UK since more than 15, 20 years. He said that the first 6 months, sir, I was given the work of taking this, even the anthropometry and putting on the growth chart, nothing else, for 6 months, that you do it properly. And I think that's important, that basics. We know that even the height is not taken, length is not taken appropriately, our whole exercise may be futile. So that's very important. And our nursing staff, they don't know the importance. What Dr. Salmi showed, that when you are measuring the height, how I would say accuracy should be there. And that reading is very important for us. Where that reading will putting on the growth chart will give you the more further information. And then the interpretation of height, age, weightage, and everything probably makes our clarity that what is some, I would say, syndromic or chronology or some group, at least you can divide that this is likely disorder of this particular group. And then you can plan the investigations. And the whole exercise, in short, what I wanted to convey, that methodologically, appropriately, meticulously, if you have done, certainly probably investigate just for confirmation. Investigation is not giving the answer. It is just my confirmation that yes, what I'm thinking is right or something else is there. And I think that investigation should be given that importance in our daily practice rather than what probably somehow unfortunately we are working in different direction, that relying more or jumping for the investigation. So I think it's not right. And even being the specialist person, Dr. Salmi, even I will say voice the same thing, that appropriate anthropometry, putting on the paper, growth chart, interpretation, that is more important than just a growth stimulation test also. Growth hormone stimulation test is for our confirmation before starting the treatment. But it does not mean that immediately if you go it. I'm sure that if you take these messages clearly, it is going to be quite useful to all of you. Thank you very much, Dr. Salmi, once again. To all the students, good presentation, I would say good participation, and I'm sure that will continue the same way in this near future also. We'll end over here, and next Saturday again we'll be there at 6 o'clock with some new guests. Thank you very much. Good night to all of you.
Thank you, sir.
Good night.